having the fetal alcohol spectrum disorder day. This year we have been observing all international fetal days, and this is one of those. So when you think of it, we seldom, I've never got a patient who's come specifically to rule out a fetal alcohol syndrome because women in our country seldom are into so much of drinking, especially during pregnancy. But yes, in a city like Mumbai, we often get women who ask us whether she can have some amount of wine. This much of wine would do. Will it harm the baby? And it is something like radiation protection. Unless you know the basics of it, unless you know the quantities that will cause a fetal alcohol spectrum disorder, it's very difficult to counsel them. So to counsel, I believe this is a very important panel that we will have today, which will have take homes, which will be pertinent to counseling such patients who ask you about the quantity of alcohol they can consume during pregnancy, would want to know how safe is it to sort of take wine once in a while, at what gestation age is it safe. So I believe these are the questions that even I would get to learn. I'm so looking forward to this interaction. So may I invite Dr. Rima Bhatt to moderate this session and introduce her panelists. Over to you, Dr. Rima.
Thank you, sir. So a very good evening to all of you. We observe September is the Fetal Alcohol Spectrum Disorder Awareness Month, and Society of Fetal Medicine takes the responsibility of observing this month to increase awareness of this disorder. Now, we understand that fetal alcohol spectrum disorder is a serious public health issue, and you'll be surprised to know it's the most common cause of preventable intellectual disability. And the most striking fact is that more children born each year with fetal alcohol spectrum disorder than with autism spectrum, spina bifida, cerebral palsy, Downs, and sudden infant death syndrome combined. So it's a huge problem. More than 1 to 5% of first grade children in the United States suffer with this spectrum of fetal alcohol disorder, and India is soon catching up. So 9 a.m. on the 9th month, that is September, is observed every year for the recognition of the importance of being alcohol-free for the 9 months of pregnancy. And Society of Fetal Medicine observes International Fetal Alcohol Spectrum Disorder Awareness Day to increase awareness among mothers to give optimal outcome to all our little fetuses. There are some common myths about alcohol use. Myth 1, wine is only safest alcohol to have during pregnancy. There's another myth, it's safe to have a regular glass of wine or other alcohol beverages during pregnancy. Another myth is drinking in moderation will cause no fetal alcohol spectrum disorder. And then the last myth is that it's a childhood disorder that goes away as the person ages. The fact is that we need to clear these myths and know what's the truth. To help me today with this are my wonderful set of panelists, Dr. Sangeeta Gupta, who's the Director Professor at Maulana Azad Medical College, and she's very active in the world of fetal medicine. Dr. Chinmay Rath needs no introduction. She's a dynamite as far as fetal medicine is concerned, who's doing some wonderful work for the society as well. We have Dr. Nidhi Gupta, who is a neonatologist from Amrita Hospital, and she's not only a neonatologist, but has done a lot of work in neurodevelopment from the London Children's King and King's College London, and she was in UK for a long time. And we have Dr. Nandini Shukla, who is a psychologist with us. So we understand that full-blown fetal alcohol syndrome represents only the tip of the iceberg relative to the alcohol-related birth defects. So my first question to Dr. Chinmay is, Dr. Chinmay, what are the fetal alcohol spectrum disorders that we can think of?
Thank you, Dr. Rima, for the question. And I think this is a very unique initiative of the Society of Fetal Medicine to apprise one and all about the ill effects of alcohol in pregnancy. And as you have rightly pointed out, it's one of the most important preventable causes of intellectual disability. So when you talk about alcohol spectrum disorders, again, like a spectrum, it's a whole umbrella I mean, it's an umbrella term covering a lot of technical aspects of alcohol spectrum disorders. So there is something called the fetal alcohol syndrome per se. Then there is also other, as this could be a complete fetal alcohol spectrum disorder or a partial alcohol spectrum disorder. Then there could be other issues which are like effects of alcohol on pregnancy, fetal alcohol effects, or you could have alcohol related birth defects. So they all come under different, definitions depending on what are the features that they show. So if it is only a few sentinel features, which are characteristic facial dysmorphologic features, and you have other parts of developmental disability, then you classify them as a just a partial alcohol spectrum disorder. If you have the complete gamut of neurodevelopmental disorder, growth restriction, facial features, including, I mean, things which can even be diagnosed in the intrauterine period, then you call it a full-blown alcohol spectrum disorder. But honestly speaking, we really don't see so many of them in the intrauterine period, or maybe we miss the diagnosis because we are not thinking of them as the first cause of problems. And in India also, we do not have so many women, as Dr. Mohit was just saying, we do not have so many women who come with a large, I mean, a very high volume drinking disorder. But later on in life, when these problems are diagnosed and all other problems that could cause these issues are ruled out, and you realize that this is an alcohol related problem, I mean, the manifestation in the in the newborn or the child is because of problems related to intrauterine alcohol intake, then you realize that these are part of the alcohol spectrum disorder. So like you have written here, in the developmental domain also, I think the pediatrician is going to address this much more than all of us, but you could have structural issues with the brain. You could have poor development of motor skills, cognition, language, not performing very well at school, and having, like, problems. Again, these problems are so gray that, there could be so many etiologies to these. But if you notice all these problems, and you have to take a history of maternal alcohol intake in pregnancy, and if that is so and that is related, then somewhere we actually feel a bit frustrated with this diagnosis, because it is again something which could have been prevented.
Thank you, Dr. Chinmay, for that. And we all understand that when we think of a standard drink, we talk of about 5% alcohol in beer, we talk about 7% alcohol in malt liquor, we talk of about 12% alcohol even in table wine, which we thought just does not have alcohol. And rum, tequila, vodka, whiskey would be about 40% alcohol. So as clinicians, we need to understand what is the alcoholic content when we talk to our patients. So my next question is to Dr. Sangeeta, that how much drinking causes fetal alcohol syndrome?
So good evening, everybody. And actually, Rima, that they say that there should be absolutely zero tolerance for alcohol during pregnancy. So there should be a complete no for alcohol. There is no recommendation that this is the safe limit of having alcohol. Nevertheless, in the past, we used to say about 2 drinks per week are not going to harm the baby. But recent recommendations, even from the National Institute of Alcoholism, says that there should be zero alcohol intake. And it also depends not only on the volume, the ill effects of alcohol during pregnancy. They're worsened if it's a binge drinking. So if a woman is having 5, 6 drinks at a go rather than those spread over the week, then that's going to have another that adds another severe connotation to the fetal infection. And it's not only this, alcohol itself is associated with so many other things, like, it causes nutritional deficiency, And these people, they have poor self-care, and they have issues of other comorbidities, coexisting diseases in them. So this as well impacts the severity of the disease. There's one more thing which I like to add is that actually you can never accurately determine what is the alcohol intake, because there is always an underreporting about alcohol intake. Nobody would really admit that this is the actual amount of alcohol I take.
Right. Thank you so much, Dr. Sangeeta. That was so indeed the current recommendations say that no amount of alcohol is safe in pregnancy. And it's not just the quantity of alcohol, because we can never determine how much is consumed, but also how frequently it is consumed, the timing of consumption during pregnancy, and other factors like maternal age, nutritional deficiencies, ability to metabolize alcohol, the socioeconomic background, and comorbidity and other physical and mental illnesses, all of which determine the spectrum of birth defects that we see with the intake of alcohol in pregnancy. Thank you, Dr. Sangeeta. So the only prevention is to simply avoid drinking alcohol during pregnancy. My next question is to Dr. Chinmay. Dr. Chinmay, how is alcohol teratogenic? Why would you say that it harms the baby? How does it harm the baby? Dr. Chinmay.
Chinmay, you're muted.
I'm so sorry. I'm so sorry.
Yeah.
So, like Dr. Sangeeta said, one of the main ways that the alcohol affects the fetus is also an indirect mechanism, because a woman who is dependent on alcohol or is heavily a drinker also does not have good self-care and the coexistent nutritional deficiencies, and sometimes even doing other drugs along with alcohol which are addictive. So that is an indirect mechanism. A woman like that will not take care of her diet, will be malnourished, and all those issues will lead to poor fetal development. However, if you talk of alcohol per se, alcohol itself is a toxin, and it has to be metabolized first in the maternal system, and if it gets transferred into the fetus, the same toxin is now in the fetal system, and it needs to be metabolized by liver enzymes. But the fetal liver enzymes are not that mature, and they will not be able to metabolize it completely, and hence the toxic effects of alcohol will be more pronounced on the fetal metabolic system. So we have alcohol here. The alcohol dehydrogenase, that kind of enzymes, it can actually converts it to acetaldehyde in the maternal system. But when it goes on to the fetal metabolism is still very immature, and therefore these toxins can directly damage the, at the DNA level only, there is some degree of damage because of the oxidative stress that is caused. So in the molecular environment, the free radicals, the damaging environment is pronounced. And because of that, the developmental milieu, the way the cells develop in the central nervous system get affected. So the alcohol can cross the fetal-placental barrier, go into the fetal system, and damage the cells at the level of the DNA in the cells itself.
Thank you so much. So it really causes, it's a toxin, it causes regulated cell differentiation, destruction of the DNA and protein synthesis, and all of this affects the baby severely. And we also need to understand that it affects the maternal immune system activation, causes some epigenetic modifications in the baby, and the offspring's immune system gets altered. There are a lot of cytokine changes that happen, and the neuroimmune system activation happens with the cytokine changes. And this is also responsible for the risk of mental health disorders in the offspring later in life. So it's a huge gamut of changes that are happening at different levels that are responsible for the different spectrum of fetal alcohol disorder. And it impacts all gestation. First trimester, there's risk of miscarriages. Second trimester, congenital abnormalities. And in the third trimester, again, fetal growth restriction. So the impact of alcohol is all gestations.
And the most important thing that we should not forget here, sorry, is that alcohol is not just alcohol isolated. See, when a woman has the habit of taking in alcohol in pregnancy, when everybody knows that in pregnancy they have to take precautions, and yet she is kind of dependent on alcohol there, there's a whole background of problems there. So there is a degree of maternal, mental ill health. There is a degree of nutritional insufficiency. There is a degree of dependency on other drugs. There can be, so many other issues which can also contribute either in an additive manner or in a complementary manner to the fetal ill health at that point in time. So the actual outcome of fetal alcohol spectrum disorder cannot be just related to the alcohol chemical impact. There are so many other things that come together.
True,
In
true.
fact,
Thank you, Dr.
smoking is more common in women who are alcohol dependent than women who don't use alcohol. And that's a huge adverse associate of alcohol.
True. Thank you. Thank you for those wonderful inputs. So, Dr. Chinmay, how in antenatal ultrasound, can you pick up some features of alcohol spectrum disorder? Are they possible? Do they have any impact? Can we do something about it?
Well, honestly, like we don't really see these issues directly as alcohol spectrum disorder related issues. Very rarely you'll have a woman who says that I have a drinking problem, a heavy drinking problem, because very many times what happens, women who are highly alcohol dependent or dependent on other drugs, they tend to discontinue pregnancies if they have happened inadvertently because of the fear of this condition. Rarely we have a woman who comes and says that I do have alcohol and can you just look for it. So we do prospectively look for all these features which you have listed there. We look for these features in the anomaly scan, and we try to rule out, because there are nomograms available for the growth and development of each and every part of the fetus. So we try and do as much accurate biometry as possible to rule out prominent conditions like microcephaly, microophthalmia. There are some facial features where the philtrum, the shape of the philtrum, there is a whole classification given there. But the thing is, these classifications are given in postnatal children. So in the antenatal period, it's very difficult to actually quantify the facial dysmorphology. Yet it is, I mean, it's a part of the protocol for screening women who are on alcohol in that way. But apart from really growth restriction, which again could be allocated to so many other conditions, at least I have not seen any case of pure microcephaly or something like that, which is because of alcohol dependence myself. But I've definitely read it in the books. And if we have a woman like that, what we do is we tend to tell her from there on not to be like indulge in more alcohol. And we assume that thereafter things are going to get better. So on the ultrasound, there is a checklist that we definitely follow. I would dread to find any of these findings, because once these findings are there, it also indicates that the teratogenicity has already taken place. And it's really not reversible at that stage. So if the teratogenicity has already occurred, then I think my counseling is going to be very grave for that woman. But most of the cases, we go systematically looking at everything and trying to rule out as much as possible. Touch wood, so far, we've not had cases where it's frank alcohol spectrum disorder in the fetus per se. But I don't know. I'd like to know about other people's experience. Maybe they have seen. Sangeeta ma'am.
Even we haven't seen any patient, and what I have read is that says it's always more of a diagnosis which is made later in life, and then retrospective diagnosis of alcohol syndrome disorder is made, spectrum disorder is made, rather than a prenatal diagnosis. This is usually a retrospective diagnosis when there are so many issues of cognition and communication skills, and then one finds out that probably the mother was having alcohol during pregnancy.
So from a practical point of view, what mostly happens is either a woman is seeking preconceptional health and she tells us that she is on alcohol, which is a very common lifestyle of today. Then we tell them that in case you are planning pregnancy, it will be good to give up on alcohol and cigarettes, at least in the preconceptional period and while you are planning your pregnancy. So they do that. Or some woman gets pregnant and comes and says that I was having the occasional drink, or I drink once in a week or twice in a week. And then we scare them all about this possibility and look at all these problems. We have never advised a woman to terminate a pregnancy because she was on, social drinking and she's conceived. But from the time she meets the doctor for the first time, the advice very unequivocally is that you should not indulge in any more of alcohol. And throughout the pregnancy, we look at all these things, supplement her nutrition, and take care of the fetus.
Right. Thank you so much for those wonderful inputs. And I think it's very important for us to now elicit a history of just not smoking, but also drinking with all our patients. It should be a part of our checklist in our history taking. That's very important, I think. And this is a very nice video that I found, and it's a startle reflex that is there very prominent in the baby till 18 weeks of gestation and disappears thereafter. But a mother who is on alcohol, and this startle reflex does not go because the neural development of the baby is not appropriate for gestation, and this startle reflex continues. So I think we should look out for the signs in case a mother gives history of alcohol intake in pregnancy. So we've discussed from the fetal medicine perspective, and we understand that facial features is a part of diagnosis. But very surprisingly, 83% of the individuals living with fetal alcohol spectrum disorder do not display the sentinel facial features. So I would now come to our neonatologist and neurodevelopmental specialist, Dr. Nidhi. What are the clinical features that you anticipate when you look at a newborn or a baby with fetal alcohol syndrome? Dr. Nidhi.
Yes, thank you, Dr. Reema, for giving this opportunity to create awareness on fetal alcohol syndrome. Good evening, all respected members of Society of Fetal Medicine. So as has already been discussed, most of these babies tend to be small. They have growth restriction, and that can mean not just their weight being less than 10 centile for gestational age, but also their head circumference. So they can have microcephaly, and their length can be small too. And as Dr. Chinmay and Dr. Sangeeta ma'am have already mentioned, there are certain criteria which can help us to diagnose. The classical ones are so short palpebral fissures, so less than 10 percentile, a smooth philtrum, and thin upper lip. So classically, we used to see some of these babies in UK, and if you see one baby, you will never forget. So thin upper lip, smooth philtrum, and short palpebral fissures are the key features. Apart from these, they can involve the eyes, so they can have drooping of eyes or the ptosis, strabismus as well, and midfacial hyperplasia. And as we can see, there can be a depressed nasal bridge, and those are the predominant clinical features that we see in these babies. And coming to the midline features, we've already mentioned, they can be midfacial hyperplasia. Apart from that, they can be skeletal dysplasia. So we can see problems to do with clinodactyly, etc., or contractures even. And to do with spine, we can have scoliosis or an abnormal curvature. And other than these, we've already mentioned ultrasound findings. So they can be cleft lip, cleft palate, heart defects like ASD, VSD, phonotruncal defects. Renal defects include horseshoe kidney or renal hyperplasia. Hearing loss can be both conductive and sensory neural, and vision issues. So in a nutshell, they can have everything from top to bottom. And apart from this, as mentioned earlier, these children tend to have long-term developmental delay. So not only there are studies showing where BSID, Bailey Scale of Infant and Toddler Development Assessment has been done, not only they have shown that the cognitive scores are less, but even significant motor delay has been seen in these children, as has been a problem with language, both expressive and understanding. And because, as ma'am already mentioned, it's probably not just alcohol, but there's a whole gamut of things. There is environmental factors, there's poor mental illness of mother, their genetic predisposition. So these children also tend to have poor attention and attention deficit hyperactivity disorder. So they'll have poor attention, poor focus, poor executive memory, which is the functioning memory. Like when we get an OTP, we tend to remember it for a few seconds. That's how our executive memory works. And these children tend to have poor of all those skills. And also there are some structural anomalies noted in the brain, like to do with the corpus callosum. There can be agenesis and hypoplasia, delayed myelination of neurons. So those are the fetal features. So there's to do with morphology, the growth restriction, and then some long-term outcomes in terms of cognitive deficits.
Thank you, Dr. Nidhi. Thank you so much. So it's basically a postnatal diagnosis where you would, on ultrasound, if we get these features, most of us will start thinking of some syndromes. We would think of getting a whole exome, and alcohol would be last on our mind. It's a diagnosis of exclusion, I think. But if postnatally you see these facial morphology, you know that there's growth restriction, and of course later in life cognitive neurological deficit, generally it points towards fetal alcohol syndrome. And generally the brain of these babies is smaller. When these babies are assessed, the size of the brain is found to be smaller. So thank you so much for these inputs. But we also understand that there are some hepatological aspects of fetal alcohol syndrome. Dr. Nidhi, could you elaborate a little on that?
Yes, Dr. Reema, some papers have mentioned about congenital hepatic fibrosis, sometimes changes even similar to adult alcohol liver disease. So there are changes that takes place, which are ultrastructural changes in the myofibroblast and the ito cells, and those can resemble the alcohol liver disease that we find in adults. So they can be hepatic fibrosis, they can be hepatomegaly. And these are the things we need to look for when we are examining a newborn post-birth and suspecting some sort of drug abuse or substance abuse in
Right.
mother.
Thank you. Thank you, Dr. Nidhi. We understand that, of course, now this baby needs some immediate postnatal care, which needs to be different from the other babies. And you would also want to keep these babies under surveillance for long-term monitoring, since they've been exposed to alcohol. So what is your strategy for monitoring these babies, and how would you go about that?
Okay. So we did see some of these babies in UK, as I've mentioned, they used to be labeled as NAS, neonatal abstinence syndrome. And one of the common symptoms that we encountered was irritability. They would be so irritable and crying constantly that the whole nursery would be, on their feet. So because of their problems with irritability, jittery behavior, non-pharmacological measures can help. Such as skin to skin, not necessarily with mother. If mother is there, that's great. But even a caregiver can provide skin to skin, swaddling, limiting the noxious stimuli. So, they don't want too much stimulation. So all the noise and the bright lights in the NICU should be minimized, and maximizing tender loving care. I think we all need that, but it's more about skin to skin care, and breastfeeding should be encouraged as long as mother is not on alcohol. And I would just like to mention a point here, although we are talking of fetal alcohol syndrome, but even in today's scenario, even in the current place where we're working, we do encounter mothers who say that, can I have a drink? And then can I still breastfeed, or can I give formula feed? So we do mention it to them that if you want to breastfeed, you can express your milk, because the alcohol concentration is maximum 30 to 60 minutes after intake. And so we avoid breastfeeding immediately after an alcohol intake. So I think that point needs to be emphasized, that breastfeeding should not be stopped. It can be continued. It's just about the timing. And then, as already mentioned, these infants can have organ damage pertaining to the heart, to the liver, to the kidneys, eyes, and hearing as well. So accordingly, we have to screen for those and address those, and get all the multidisciplinary team involved. So early intervention is the key. And if we do a close neurodevelopmental surveillance, if we provide support to family, ensure skin to skin contact, swaddling, gentle rocking of these babies, then that can go a long way.
Thank you, Dr. Nidhi. We do understand that the babies with the fetal alcohol spectrum disorder are often misdiagnosed. They're underdiagnosed, and they're co-diagnosed with autism spectrum disorder, attention deficit disorders, and a lot of other disorders that we can think of. So I would, at this point, request Dr. Nandini Shukla to let us know what are the development impacts of fetal alcohol spectrum, and how do you differentiate them from the other disorders that are so closely mimic fetal alcohol spectrum disorder?
Hello, good evening, everyone. Thank you, ma'am. Like you said, ma'am, yes, all the other disorders that are mentioned here, like ADHD, autism. So there are certain traits that are present in FASD as well. But if we see closely for ADHD, we do not diagnose before 6 years of age. But in FASD, if there is predominant inattention and it is present before 6 years of age, then we'll have to look at the previous history if there is, presence of alcohol intake in the mother. Again, if we come to autism, like the sensory issues, like ma'am rightly said that they have to reduce the stimuli even for the babies. But other symptoms like stereotypical movements. So all these other traits are present which can help us in differentiating. Also, when we do neuropsychological assessments, if we see children with ADHD, they can be identified using behavior checklists and measures of ability to focus and sustain. But when we look at FASD, they have deficits specifically in visual spatial skills, encoding of information like word pair associates, and then set shifting, basically flexibility in problem solving. So that can be seen through Wisconsin card sorting test. So they will perform very poorly in comparison to children with ADHD.
Great. So then we do definitely be looking at some secondary disability also, Dr. Nandini. So what are, they must be coming to you for a psychological rehabilitation. So what kind of problems do you generally see when you have babies as they're growing up with fetal alcohol syndrome?
Yes, ma'am. So what we see is basically a poor impulse control. Then there are learning difficulties for which rehabilitation is required. Behavior modification is required. But the problem here is that when we look at behavior modification and other kind of disorders like ADHD, it is relatively easier. But when it comes to FASD, behavior modification, traditional behavior modification would not work because they do not have those system of rewards set up in place. So there is poor understanding of cause and effect. So we have to look at, what is causing this kind of behavior in a particular environment. So we have to change antecedent and consequences as well. Make a different kind of reward list with these kind of children. For learning disability, ma'am, again, special education is encouraged. So there is something called cognitive control therapy. So what we do in this, children, they are helped with strategies that facilitate their ability to acquire and organize information more easily because they have difficulty in categorization as well. So it encompasses body position and movement and self-awareness, which will help with the visuospatial deficits. And there is focal attention, processing of information in presence of distraction stimuli, then controlling external information, and then categorizing information. Also, ma'am, we need to work with parents because like ma'am also said that there is personality disorder probably in the parents, which is leading to substance abuse. So there will be obviously poor caregiving basically with these kind of children. So we need to work on parents as well. We can do
Thank you,
CBT
Dr.
and DBT.
Yeah. Great. So thank you, Dr. Nandini. So it's not something that finishes off with the baby. It's something that carries on in life. And it is huge amount of secondary disability, mental health problems, dependent living, employment problems, disruptive school experience, trouble with law, and again, alcohol and drug abuse. So it's a very prolonged kind of rehabilitation that's required because of the different cognitive and behavioral problems that these babies have to face. And in addition to this, there is poor coordination, hyperactive behavior, learning disability. So it's not normal schooling. It's not normal growth for these children. It's always a special kind of care that's required for babies who grow up with fetal alcohol spectrum disorder. And as you mentioned, the treatment, there is no definitive treatment available. It's just behavior and education therapy and a lot of parental support that is required for these babies. So it's it's quite a bit of work that is required at both ends, both from the child who suffers from this problem and also from the parents. And I was surprised to know that the life expectancy of these children is less. 19% of deaths are caused by issues of mental health and suicide, and 92% have co-occurring mental health issues, and they're 19 times more likely to be jailed at some point of their life. So these are numbers that really frighten us, and that's how it's so important to increase awareness about this disorder that is associated with fetal alcohol, with alcohol intake in pregnancy. And a 20-year-old boy can have social skills of a 7-year-old. This is the level of dysmaturity that happens with babies or as they grow into adults of fetal alcohol spectrum disorder. So my question to Dr. Sangeeta is that can we prevent it? Yes, I think the only way is not to have alcohol. So who can offer maximum support to this child? I mean, this child or the mother when she is in her antenatal period?
So I think charity begins at home, and it is the person who is a partner to you who can really make the biggest difference. So it has been observed that in about 40% of the women, they will be able to control their habit of drinking if there is a support from the spouse or the partner. And particularly, this is very effective if the spouse also stops drinking completely with the woman. So this is the best way to help her. So as in any other condition, it is the couple counseling which is important. And it is very important that probably for the physician, as a physician, we may not be able to help much other than showing the way, but it's the partner who can really make a huge difference in this. And apart from this, yes, the support groups, the other help groups, the help from a psychologist or a counselor would definitely have more impact.
Yes, you're right. So I
Additional
think,
impact, I would say.
yeah, correct. Thank you. So I think it's the partner, the family that's important. In our country, probably we still don't accept alcohol as the way of life in the society, and consulting a psychologist or having support groups is still not the way as far as our country is concerned. But yes, in years to come, this will become a problem, and we have to be prepared for what's coming in future. And
But
yeah.
Rima, with the current generation in the metropolitan cities, we can't keep our eyes closed.
Yes.
It's a writing on the wall.
Yes.
So that's,
Agree with
I
you.
think that's a compliment that you have thought of it beforehand. And awareness probably in this area can make a huge difference.
You're right. Absolutely right, Dr. Sangeeta. And so my another question is, can drinking affect fertility? So is that the way of counseling the male partner? I mean, would it make a difference?
In fact, yes, we all know that at least that yes, infertility is quite rampant in our country. And it's a standard protocol to inquire about alcohol intake in the male partner. And now literature supports that yes, intake of alcohol will lead to compromise in the sperm count of the person, the quality as well as the quantity of the sperms. So yes, when you're doing a preconceptual counseling, again, it is the couple which is important, and in the lifestyle changes. Even if the partner is drinking, then maybe they may have problems in conceiving later on. And this is something which is very much preventable.
Yes. So
So
I
they
think,
can be advised accordingly.
yes, Dr. Sangeeta. So I think as a part of preconception counseling, alcohol intake should be in the guidelines that we have as to how we need to counsel them. When we counsel them about folic acid, we tend to counsel them about some consanguinity, different disorders. We also need to counsel a lot on the alcohol and how it can affect the baby. So we also need to understand that we can prevent by stopping alcohol. But yes, those children and the adults who are affected by fetal alcohol syndrome, there is a positive side to all of them. They can be creative, athletic, caring, determined, friendly, artistic, generous, helpful, and willing. So if we have in our society people who are affected by fetal alcohol spectrum disorder, we need to take them as they are in the society and help them the most that we can. this is also a very important part of the awareness about fetal alcohol spectrum disorder. So I think the only message is that for a strong future generation, there can be no alcohol at all during pregnancy. And Society of Fetal Medicine, like the other responsibilities it has taken, led by Dr. Ashok Khurana and his team, we are with this little baby in their mission. When they say that we are arriving soon, we will help to prevent fetal alcohol syndrome. Thank you so much. I would request if there is a take-home point from our panelists, they could give one take-home point for our audience.
Dr. Reema, I think it has been a real eye-opener, and this discussion has been really, really useful for all of us. So most importantly, I would say taking that history in a non-judgmental fashion. You know, sometimes when we take the history, the language, the tone, the kind of, you know, do you have alcohol? Are you addicted to this something? I mean, the tone itself can sometimes deter people from giving that history. So in a very non-judgmental manner, accepting that the social fabric has changed. So just telling them, you know, is there any substance or any thing that you are habituated to? Do you have occasional drinking? You can get that history in a forthcoming manner, number one. Number two, the prevention of this problem in the mother also may require a complete counseling. So because nobody wants to be dependent on anything. So it is a personality issue sometimes, and that needs proper counseling. So if needed, they should meet a proper counselor to give off that, because you just can't tell a person that, okay, no alcohol from tomorrow. If the person is dependent, that is going to lead to more, you know, problems thereafter. So let's be accepting of the fact that yes, alcohol has become part of society now. And because pregnancy is a special care, like you said, generating awareness is so important. And let's accept it and try our best to prevent fetal alcohol spectrum disorder.
Thank you. Dr. Sangeeta, would you?
Yeah, I think Reema, here there is a lot of role of awareness and prevention. We know that the generations to come have adopted it more as a day-to-day lifestyle. We are all aware of it. They are going to be the future mothers. And I think it will go a long way in spreading awareness about this. I would also appreciate that these young women are very, very particular about the health, their own health and the health of the fetus during the pregnancy when they conceive. So I think that's really where we can hit the rod when it's iron when it's hot and make a difference. And second is, of course, the preconceptional period is very important area with perspective to prevention of fetal alcohol syndrome.
Thank you. Thank you, Dr. Sangeeta. Dr. Nidhi, would you give your one final word for today's panel?
Yes, Dr. Reema, I think because I'm a neonatologist, we are very pro breastfeeding. So my only take is that we should promote breastfeeding in all scenarios. Especially we should emphasize, if there is a baby born, we should emphasize to mothers to at least avoid alcohol in the first 6 weeks, because that is when the production is being established. And as we all know, alcohol can slow down the production. The second is the close neurodevelopmental surveillance. Now we all do that and we all do early intervention, but early intervention starts as close as birth. So we should promote more bonding and more activities which can help in the overall in improving the developmental trajectory of these babies.
Thank you. Thank you, Dr. Nidhi. Dr. Nandini, would you, from the from a psychologist perspective, would you want to add on something?
Yes, ma'am. Thank you. Like ma'am rightly said, that nobody is willing to be dependent on something. And just by saying that you should not take alcohol, you should not take any substance, you know, it doesn't really help, because they also feel helpless. They don't know how to go about it. So as a psychologist, what we can do is we can help them with motivation enhancement therapy. We can help them to get rid of, at least, like ma'am said, first 6 weeks. So it is one step at a time. So let's start with that. At least for this time, do not take it. And we'll help you how to do that, how to, go about craving, how to manage your urges to have substance. And then we can move on to dialectical behavior therapy and really work on core issues of personality.
Right.
So I
Thank
think
you.
that can really help.
Thank you so much. Thank you. So I would now request our expert, Dr. Ashok Khurana, to give the final word and to take on the discussion from here.
Thank you, and my congratulations for this very crisp but really full of insight panel. And the panelists have been absolutely superb. We have realized that, yes, we need awareness. And that is really the first step, to understand that the problem exists and there is awareness. And let's go step by step. The first thing that Chinmay highlighted was our tone when we ask these things. And we do understand that alcohol, smoking, and recreational drugs, all three go together these days. And therefore, it is becoming extremely important that in the same breath, and often in a casual manner, that we should ask this question, be sensitive and look into the eyes of the patient when we're asking this question, and make sure that we get an appropriate answer. The next step, of course, is to try and see where Society of Fetal Medicine can step in and try and increase awareness in school-going and college-going individuals. And we do understand that school-going individuals currently have a greater sensitivity and openness about having things like this having an impact on their mind. And that can start as early as class 1, 2, and 3, rather than sit and wait for when they get older. We feel that how can we teach alphabet along with alcohol? And the fact is that you can, and that these children are known to actually reverse the effect, the dependency on alcohol. Then, of course, we have this, we mentioned the neonatal problem of drinking, but we must also realize that our staff has to be very sensitive, because a large number of women who have been used to drinking alcohol secretly may not be able to cope with the neonatal period at all. And therein lies the problem. So the number of bottles that we can unearth from within the toilets of our wards, as well as private rooms, etc., we should be aware of that, and the staff should be aware of this. And we should also train our staff to say that, for heaven's sake, please do not take money and provide alcohol to our patients. These are things that are happening in hospitals in modern days, and we don't seem to be paying attention to them. And this is really the way to go about it. Within this business of trying to identify within the period of pregnancy, we do understand it's truly a losing battle, because subtle facial abnormalities such as this are extremely unlikely to be picked up. And yes, we have alcohol down as part of the differential diagnosis, but not really on top. So most of these are going to be missed, and we will need to find other ways of paying attention to this. And therefore, you must be aware of the fact that, yes, when you're talking to a patient, even during an ultrasound scan or during a clinical interview, that something doesn't seem to be right. As doctors, we seem to be pretty well trained on seeing that, look, I'm not able to put my finger on it, but something is wrong here. And we really need to emphasize on that. And I know that a webinar like ours is going to be very widely seen, because our webinars are so well seen, and this will go a really long way. So my very special thanks to all of you to have put this webinar together, to give the facts exactly as they are, and to emphasize the fact that no alcohol is safe in pregnancy. There is no doubt that, yes, people have had alcohol throughout pregnancy and had normal children. That's the next question that a lot of us really get asked. So if no alcohol in normal children have happened, the patient starts wondering that, look, I think I'm just wasting my time and I shouldn't really have done any of this. But that is not the way we should approach this problem. The way we need to approach this problem is that, look, we let our patients know that we don't know when to stop. Most people who drink more will have not a clue on when to stop. And that again is that then friends should not be encouraged to say, okay, it's okay, all over England they drink port in the winter, and port is a form of alcohol and they can manage it, or that in England they drink sherry and they seem to be doing pretty well. That may not necessarily be something that friends should be saying. We do understand that the last word on alcohol is not written, and that it may be not as unsafe, but that is not the reason why we should encourage it in any sort of way. And that is what we have learned this evening. And I do hope more and more people watch the webinar. There was a question on how to get a recording of our webinars. And for those of you who are new to the Society of Fetal Medicine, all our webinars come online within a few weeks, occasionally a few months, depending on copyright issues. And then we have them on the SFM YouTube channel, where all of us can actually watch them. There is no other question. And so with that, I take this opportunity to thank once again everyone who has come in to attend this, everyone who will be then spreading the message, to Dr. Mohit Shah for leading SFM and also leading the webinar tonight, to Colonel Rima Bhatt for having put this together and actually making a list of days where we need awareness, where a lot of us are unaware. We've had some excellent programs on things like sickle cell, for instance, which have now resulted in a program being undertaken in 7 states at the same time, which is fantastic. And I do hope alcohol goes in the same way. And my thanks, of course, to our panel for their fantastic inputs. A very special thanks to Dr. Chinmay Rath, Dr. Nandini Shukla, Dr. Sangeeta Gupta, and Dr. Nidhi Gupta for being with us this evening. And with that, thank you very much.
Thank you. Good night. Good night,
Good
everyone.
night. Thank you.